Alcohol use disorder is an mental health issue, mental disorder. Look at this picture, shows that overuse of alcohol, loss of control, brain images, normal brain, alcoholic brain, pre-treatment brain. After 4 treatment session, look at this. A detail going on. Introduction. Alcohol use disorder is a chronic and relapsing condition characterized by an inability to control alcohol consumption despite adverse social, occupational, or health consequences. It encompasses a range of problematic drinking behaviors from alcohol abuse to alcohol dependence, affecting millions of worldwide and contributing significantly to the global disease burden. Definition. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, AUD is defined as problematic pattern of alcohol use leading to significant impairment or distress manifested by at least 2 specific criteria within a 12-month period, such as increased tolerance, withdrawal symptoms, unsuccessful attempts to reduce drinking, or continued use despite harm. Types. 1. Mild AUD meets 2 to 3 criteria. 2. Moderate AUD meet 4 to 5 criteria. 3. Severe AUD meets 6 or more criteria. Criteria for alcohol use disorder AUD. The DSM-5 Diagnostic and Statistical Manual of Mental Disorders 5th edition outlines 11 criteria for diagnosing AUD. A diagnosis is made based on the presence of at least 2 of these criteria within a 12-month period. DSM-5 criteria for alcohol use disorder. 1. Impaired control. Alcohol is consumed in large amounts or over a longer period than intended. Persistent desire or unsuccessful efforts to cut down or control alcohol use. 2. Craving, a strong desire or urge to drink alcohol. 3. Time spent. A great deal of time is spent obtaining, using, or recovering from alcohol. 4. Neglect of obligations. A current alcohol use result in a failure to fulfill major obligations at work, school, or home. 5. Continued use despite problems. Continued alcohol use despite persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. 6. Giving up activities. Important social, occupational, or recreational activities are given up or reduced due to alcohol use. 7. Hazardous use. Recurrent alcohol use is situations where it is physically hazardous. Example, drinking and driving, operating machinery. 8. Tolerance. A need for markedly increased amount of alcohol to achieve intoxication or the desired effects. Markedly diminished effect with continued use of the same amount of alcohol. 9. Withdrawal. Symptoms such as tremors, sweating, nausea, or seizures when alcohol use is stopped. Alcohol are closely related to substances like benzodiazepines is used to relieve or avoid withdrawal symptoms. 10. Physical or psychological problems. Continue use despite knowing it is causing or exacerbating physical or psychological problems. 11. Loss of control. Over drinking. Persistent inability to limit or stop drinking even when the individual wants to. Application for a diagnosis of AUD. A thorough history and assessment of these criteria are performed. Screening tools like the AUD-IT, alcohol use disorder identification test, and the CAGE questionnaire may be used for primarily evaluation. Proper diagnosis aids in determining the severity and guiding treatment planning. Causes. 1. Genetic factors. Family history of AUD. Genetic variants in alcohol metabolic enzymes. 2. Environmental factors. Peer pressure, early exposure to alcohol, stressful life events. 3. Psychological factors, anxiety and depression, low self-esteem, history of trauma. 4. Socio-cultural factors, cultural norms around drinking, availability of alcohol. Risk factors, 1. Family history of alcohol dependence, 2. Male gender, 3. Early initiation of drinking, 4. History of mental health disorders, 5. Social isolation or lack of support systems. 6. Chronic stress or trauma. 7. Living in environments where alcohol is easily accessible or normalized. Complications: A. Physical health, liver diseases, psoriasis, alcohol, hepatitis. 2. Cardiovascular problems, example hypertension, cardiomyopathy. 3. Pancreatitis. 4. Malnutrition. 5. Increased risk of cancer, example mouth, throat, liver cancers. B. Mental health, depression and anxiety disorders. 2. Cognitive impairment or dementia. 3. Increased risk of suicide. C. Social, relationship conflicts, job loss or financial inability. 3. Legal issues. D. Others, fetal alcohol spectrum disorders in offspring. Pathophysiology. The pathophysiology of AUD involves complex interconnections between the brain, neurotransmitters, and organ systems. Below is a step-by-step explanation of the process. 1. Initial alcohol consumption, absorption, disruption. 2. Neurochemical effects. Alcohol enhances the activity of gamma aminobutyric acid, GABA, an inhibitory neurotransmitter leading to sedation, relaxation, impaired coordination. 3. Development of tolerance. With repeated exposure, the brain adapts to alcohol. Downregulation, reduction of GABA receptors. Upregulation, increase of glutamate receptors. 4. Chronic alcohol use, neuro adaptation, dopamine dysregulation. 5. Dependence, reduced GABA activity, excessive glutamate activity. This imbalance results in withdrawal symptoms. 6. Systemic toxicity. 7. Organ specific pathophysiology. Liver fat accumulation, inflammation, fibrosis and scarring, brain, structural and functional damage, particularly in the frontal lobe, memory deficit, cardiovascular defects, hypertension and alcoholic cardiomyopathy, pancreas, chronic inflammation leading to pancreatitis. Immune system, impaired immunity and increased susceptibility to infections. 8. Relapse and chronicity. Dysregulated brain circuits in chronic AUD make individuals prone to relapse. Stress, environmental triggers and changes in neurotransmitter systems perpetuate the cycle of addiction. Signs and symptoms. 1. Behavioral. Drinking larger amount over larger periods. Inability to limit alcohol consumption. Neglecting responsibilities due to drinking. 2. Physical. Tolerance to alcohol, withdrawal symptoms, weight loss or malnutrition. 3. Psychological. Craving for alcohol, memory blackouts, mood swing or irritability. Diagnosis. 1. Laboratory test. 1. Elevated liver enzymes, ALT, AST, GGT. 2. Macrocytic anemia, MCV elevation. 3. Electrolyte imbalances. 2. DSM-5 criteria. 1. At least 2 of 11 criteria must be met within 12 months. Three, clinical history, detailed alcohol use history. 2. Family and social history. 4. Screening tools. 1. CAGE questionnaires. 2. AUDIT alcohol use disorder identification test. Nursing diagnosis. 1. Risk for injury related to impaired judgment and coordination. 2. Imbalanced nutrition less than body requirements. 3. Ineffective coping related to substance dependence. 4. Disrupted thought processes related to withdrawal effects. Management. Medical management. 1. Detoxification. A. Managed withdrawal with benzodiazepines. Example, diazepam, lorazepam. B. Monitoring for complications. Example, seizures, delirium, tremors. 2. Medications. Disulfiram to deter alcohol use. B. Naltrexone to reduce cravings. C. Asaprosate to reduce neurotransmitter balance. 3. Nutritional support. thiamine to prevent onychus encephalopathy. B. Multivitamins and folate. Nursing management. 1. Assessment. Monitor for withdrawal symptoms. B. Assess nutritional status and hydration. 2. Intervention. A. Provide a calm and safe environment. B. Encourage hydration and balanced diet. C. Education on the risk of alcohol use. 3. Support. A. Build therapeutic report. B. Facilitate participation in support groups. Example, Alcoholic Anonymous. Treatment. 1. Behavioral therapy. Cognitive behavioral therapy CBT to identify and change drinking triggers. Motivational interviewing to enhance commitment to change. 2. Psychosocial interventions, support groups, family counseling. 3. Rehabilitation. Inpatient or outpatient programs for long-term recovery. Psychosocial medicine. 1. Emphasis on holistic care addressing mental, emotional and social well-being. 2. Counseling to rebuild relationships and enhance coping skills. 3. Community-based programs to support reintegration into society. Prevention. 1. Primary prevention, public education on alcohol risks, restricting alcohol marketing and sales. 3. Secondary prevention, early identification through screening, intervening in high risk populations. 4. Tertiary prevention, preventing relapse through continuous care and support. In conclusion, alcohol use disorder is a complex, multi-factored condition requiring a multidisciplinary approach for effective management. Early intervention, ongoing support and education are crucial to preventing and mitigating its effect on individuals and society. Thank you. Have a nice day.